Ok, buongiorno a tutti. Buongiorno, Professor Nicoli. Buongiorno. Ciao, Graziella.
Hi, Arif. Good morning.
Good. Okay, so we'll just wait a minute or so for everybody to connect and join. As you know, the format will be 15 minutes for you to present the article, and then we'll have a 15 minutes interactive Q&A with Professor Nicoli to discuss this field. So we'll get started in just about 1 minute or so once everybody else has joined, and then we can go. I just invite you to share your screen.
Can you see it?
No, not yet.
Okay, one moment.
Great, it's working. Okay, so time is good. So good morning, everybody. Welcome back to Journal Club. It's great to have you all here. Especially today, we start and launch a new initiative, which is that of YouTube Live. So you'll be able to now follow our Journal Club sessions, both this one and future ones, not only via the Zoom link that we send out to you, but also live from YouTube. So it gives me great pleasure to welcome Graziella Pompei from Ferrara, a real working in a place with a lot of physiology expertise, which will be really great to hear about for this paper, and also Professor Nicoli from Parma, who will also be joining us to share his insights and expertise. So Graziella, over to you.
Okay. Thank you, Arif, for your presentation. Good morning, everybody, and thank you, Professor Nicoli, for your participation today. Today, for me, is such a big pleasure to be here as a presenter, and we are going to talk about the study. Okay, can you see it? Okay, the combined assessment of FFR and CFR for decision-making in coronary revascularization from the multicenter international ILIAS registry, just published in May of this year on JACC cardiovascular intervention. About the starting from the background, we can say, as you know, that physiology-guided PCI using intracoronary pressure measurements has become the standard in contemporary clinical practice. The recent use of FFR was shown to reduce the number of revascularization procedures while preserving clinical outcomes up to 5-year follow-up. But up to 1/2 of vessels with abnormal FFR treated with medical therapy did not require revascularization within 5 years following the assessment. And more than 20% of vessels with normal FFR had adverse events or revascularization within 5 years. So additional tools are needed in order to optimize the selection of a vessel that should undergo revascularization. CFR is an index that gives information about the functional capacity of the coronary circulation to increase blood supply upon an increase in the pand. And as you know, normal CFR is associated with a favorable prognosis, and reduced values of CFR carries higher rate of adverse events. So the combined use of FFR and CFR would allow the identification of the specific coronary pathophysiology by a comprehensive assessment of the epicardial and the microvascular function. Further research is needed to elucidate a potential incremental value of the combined assessment of FFR and CFR for decision-making in clinical practice, because the data on the clinical implication of distinct patterns of FFR and CFR are lacking. The defined flow study was the only prospective study on combined CFR and FFR measurement. And this study showed that vessels with either low FFR or low CFR are associated with higher events rates compared with the vessels with normal FFR and normal CFR, but exhibit similar event rates compared with vessels that undergo revascularization. The main aim of the study we present today is to demonstrate the clinical implication of distinct patterns of functional evaluation using a combined assessment of FFR and CFR for decision-making. Talking about the ILIAS registry, this is a global and multi-center initiative composed by 20 expert medical institutes from Netherlands, Korea, Japan, Spain, Denmark, Italy, and the United States. And it is a registry pooling lesion level coronary pressure and flow data and vessel level clinical outcome data. About the inclusion criteria, patients who underwent coronary angiography and comprehensive invasive physiological assessment of at least one coronary artery using coronary pressure and flow measurement were included. And patients with hemodynamic instability or significant valvular pathology or prior coronary artery bypass graft surgery and culprit vessels of acute coronary syndromes were excluded. The presence or the absence of the obstructive coronary artery disease was assessed visually, and the diagnostic coronary angiography was performed according to the standard techniques. Then an invasive physiological indexes measurement was performed, and the instruments used were or a separate pressure and Doppler velocity guide wires, or dual pressure and Doppler flow velocity guide wire, or temperature sensitive pressure guide wire. Intracoronary nitrate before physiological measurements was administered, and the maximal hyperemia was obtained through the infusion of adenosine or intracoronary bolus injection of adenosine or intracoronary bolus injection of nicorandil. FFR value was calculated as the ratio between the mean distal coronary pressure to the mean aortic pressure, and CFR was calculated as the ratio of the hyperemic coronary flow to the basal coronary flow. A clinical follow-up was obtained at outpatient clinical visit or by telephone contact in order to ascertain the occurrence of the target vessel failure, defined as a composite of cardiac death, acute myocardial infarction, and clinical-driven revascularization of the target vessel. Among the coronary artery disease population, complete physiological data about the clinical vessel follow-up was obtained in 2,143 patients, with a total of 2,725 lesions. The mean age was 64 years old, and the 26% of the participants of the population were women. The mean values of FFR and CFR were 0.82 and 2.6 respectively, and vascularization was performed in 785 of vessels. The study obtained a median follow-up of 2.9 years. This figure shows the distribution of the FFR and the CFR values agreements in the overall population, and as well as across the flow measurement techniques. As you can see, the majority of vessels displayed concordance between FFR and CFR, with concordant normal CFR and FFR in 48% of vessels, and low CFR and low FFR in 17% of vessels. The discordance between the two values occurred in 33% of vessels, and the prevalence of discordance was similar between Doppler and thermodilution measurements. This is a table that shows the clinical angiographical and physiological data in the population across the 5 different groups. And about the results, we can say that during a 5-year follow-up period, at least one target vessel failure event occurred in about the 8% of vessels. The majority of events were target vessel revascularization, which occurred in 5% of vessels. And in patients whom revascularization was deferred, age, diabetes, hypercholesterolemia, a family history of cardiovascular disease, prior myocardial infarction, beta blocker use, nitrate use, and ejection fraction were associated with 5-year target vessel failure rate. After adjustment for these confounders, there were strong independent association between CFR and a 5-year target vessel failure rate, and between FFR and 5-year target vessel failure rate. This is the central illustration of the study that depicts the Kaplan-Meier curves among the 5 different groups according to the concordance or the discordance of the values. And this is the table 3 that depicts the 5-year Kaplan-Meier estimates of the target vessel failure and its individual components across groups. As you can see, compared with concordant normal FFR and normal CFR, concordant low FFR, low CFR carried the highest risk for target vessel failure, significantly higher than in vessels underwent revascularization. The 5-year target vessel failure in revascularized vessels was significantly compared with vessels with concordant normal FFR and CFR, in which revascularization was deferred. And discordance were both associated with an increased target vessel failure rate compared with the concordant normal FFR and CFR. No difference in 5-year target vessel failure rates was observed between the two discordant groups, or between either of the discordant groups and that group that underwent revascularization. Finally, no significant interaction between this association and the method used to measure coronary flow was observed. About the findings of the study, we can document that disturbed coronary hemodynamics are associated with impaired clinical outcomes. 2, second, vessels with normal FFR CFR had excellent 5-year clinical outcomes with a very low target vessel failure rates, significantly lower than in vessels that underwent vascularization. Third, vessels with either low CFR or low FFR were associated with the 5-year event rates equivalent to the event rates in patients undergoing revascularization. So this data suggests that revascularization in vessels with a good combined abnormal FFR and CFR reduce the risk for future adverse events, as revascularization is associated with a significantly lower event rates during the follow-up compared with the medical therapy alone. About the comparison with the pressure wire guided decision, we know that in the FFR positive stenosis treated with only medical therapy, no adverse events in about 1/2 of vessel were observed. Contrary to the FFR negative stenosis treated with the medical therapy alone, in which adverse events or clinically indicated revascularization is observed in about 23% of vessels during a 5-year follow-up. So a complementary tool is needed to optimize the selection of the vessel in which the risk-benefit ratio is guided from by the assessment. So several retrospective studies identified the prognostic value of combined application of FFR and CFR. And the ILIAS registry documents that event rates in vessels with either low FFR or low CFR values are as low as the event rates in vessels that undergo coronary vascularization. Finally, the 20-month event rates in the present study are comparable with the event rates documented in the defined flow study, further strengthening the findings of this study. And about the study limitation, the decision-making to perform PCI for the stenosis of interest was at the discretion of the operator. Second, the evaluation was performed only in patients with stable coronary artery disease, and no detailed information on the medication profile during the follow-up were available. And finally, this suffered from the limitation of a retrospective registry. So in conclusion, we can say that in vessels in which revascularization is very disturbed, coronary hemodynamics are uniformly associated with increased event rates compared with vessels with normal FFR CFR. Vessels with discordant FFR and CFR values are associated with 5-year event rates equivalent to those of vessels that undergo revascularization. Vessels with combined low FFR and CFR exhibit event rates that are significantly higher than those after revascularization. And a combined FFR-CFR assessment supports risk stratification and clinical decision-making for coronary revascularization. So after this, thank you for this attention.
Great. Well done, Graziella. You took a bit of a challenging paper and presented it very, very nicely. So very well done. Professor Nickley, if I can invite you, please, to give us your comments, first of all, on this article, and then we can move into the field a little bit and take any questions from the audience.
You can hear me?
Yes, Prof, I think you're mute.
Okay. Professor Nickley, thank you for your participation. I want to open the discussion starting from 2 simple questions. So, when is the correct case to perform CFR evaluation in the cath lab? And in your clinical practice, how CFR, in addition to FFR, guides your choice?
Professor Nickley, sorry, you're still on mute.
Okay. He isn't here.
Now, can you hear me?
Okay.
Yes, now we can hear you.
Okay. So thank you for this kind invitation and a nice presentation. But I think you have chosen a very complex paper and a very complex scenario, because I should inform you about the history of this registry and about the history of the defined flow study, because I was part of both studies. But regarding the defined flow study, during the analysis of the results, there was some discrepancy in the interpretation of the results between among the investigators. So the truth is that at least half of the investigators decided to come out of the study, because there was a discrepancy between the core lab assessment that was planned in the defined flow study and the result provided by the Neil Johnson group. So in parallel, this registry, the ILIAS registry, it is of course a retrospective registry, was planned and was performed, and is quite a huge study, because more than 2,000 lesions were assessed. So the point, the crucial point here is the relative role of the flow against pressure. So this is quite a complex scenario, because there is a group of people that think that flow is more important than pressure. So both in the defined flow and in this registry, the crucial point is regarding lesions with abnormal FFR but normal flow. Because of course the two extreme, I mean those with completely normal hemodynamics, so normal FFR, normal CFR, the situation is clear that the prognosis is good. Instead, the other extreme, those with abnormal FFR and abnormal CFR, the prognosis is worse, so you need to revascularize. The crucial point is in the discordances. and especially in those with normal flow, so normal CFR. This registry shows that if you have a normal flow, the event rate is similar, it's quite similar, not exactly the same, as compared to those revascularized. So if you treat medically a lesion with normal flow, you have an event rate that is similar to that are revascularized. But in order to understand what is going on, what is happening, you should always remember that often we are talking about borderline FFR value, and if the flow is normal, in this case, in some cases you may overestimate the FFR value. I mean, if you have a normal flow, you can create a false pressure gradient. Can you understand me? This is a crucial point, because if the flow is really increased, the pressure gradient across the stenosis may increase. So you can have FFR value lower than 0.8, but the stenosis is not truly creating a real gradient. And the impact of this stenosis from a prognostic point of view is not important. Is not important. So what is the problem of both the defined flow and the ILIAS registry? The problem is that this kind of stenosis are not randomized. So there is not a randomization of medical therapy against revascularization, both in the defined flow and in the ILIAS registry. So we cannot have a definitive answer to this question, because in both studies, in these studies there is a comparison of medical therapy, but it is not randomized. It's a registry, it's a retrospective registry with limitations, of course. But the similar situation is in the defined flow. A different situation is in the group with another discordance. I mean normal FFR but abnormal CFR. In this case, you should always take in mind that if the flow does not increase, you can have normal, fastly normal FFR. So the FFR should be lower than 0.80, but is normal just because there is not full microvascular dilatation. Can you understand me? There are two extreme. In one extreme, you have a higher increase in the flow, normal CFR, so the flow increase very much. In the other case, you have no increase in the flow. So the situation is quite complex, because in this case of discrepancy, you should always take in mind these possibilities. But again, I think of course, we need to adapt the information to the patient. So regarding your question, the clinical utility and the clinical utilization. At the moment, I think, especially in Italy, there is a low penetration of these indexes. There is a low penetration of FFR, and you can imagine what can happen about flow. So I think we need to use more physiology, and probably the interpretation of this data should also take into account the microvascular resistance. So there is a third parameter, is FFR, CFR, and microvascular resistance. Just because CFR give you an information about both epicardial and microvascular level. So you should distinguish. if the problem is the microcirculation of the epicardial vessel. So having also information about the microvascular resistance, the basal microvascular resistance, the hyperemic microvascular resistance, and the delta between the basal and the hyperemic microvascular resistance can give you more information, can allow you to understand what is the situation in that patient. Of course, you should always use this information in the individual patient. So you should also take into account also clinical data, so the clinical presentation of the patient, and data coming from the literature, because in many cases we forget that especially for stable patients in the last years we have very important data coming from big studies, for example the ischemia trial. So we should use physiology trying to forget that we are in interventional cardiologists just focusing on the stenosis, and we should try to adapt this complex information in each individual patient based also on the data available from the literature. So I hope to have been clear, because this is a very complex study, a very complex situation, and I think that it's been difficult for many investigators deciding to come out from the defined flow study, but there is still this huge controversy about the relative weight of flow versus pressure. So this is an open issue, I think, and probably we need a randomized study.
Okay.
Thank you for the insights and the very useful and helpful explanation. So Giorgio, please.
Good morning. Congratulations, Graziella, for the presentation, and thank you, Professor Nicoli. I have a question for you, Professor Nicoli. What is the adjunctive value of measuring CFR with FFR? Because with the available data, maybe nowadays when we find an FFR positive lesion, we will revascularize. So sticking to previous trials. And what can we do with patients who have a negative FFR and a reduced CFR? And do you think that by tackling microvascular dysfunction, we can improve the prognosis of this patient? I mean, is the association between microvascular dysfunction and worse prognosis at follow-up association or causation?
No, thank you, Giorgio. I think that in case of patient with the normal FFR but abnormal CFR, there are a huge amount of data showing that the prognosis, even at long term, is worse. So what to do? At the moment, this is a gap in the treatment of patients. The treatment of microvascular dysfunction is an area of investigation, because there are not drugs specifically designed for the treatment of microvascular disease. But I think that in the case of microvascular dysfunction, probably we need more research, because we need to understand what type of microvascular dysfunction is going on in that patient, because there may be some structural alteration or some functional alteration. In some patients, there is a mix of these two problems. There are problems of vasomotility. So it's not just one type of microvascular dysfunction. There are very nice studies coming from the Javier Escané group from Madrid, for example, that have clearly shown that, for example, if you look up the density of the microvessel in post transplantation heart, is a huge variation across patients. So this is a typical structural alteration due to low density of the microvessel. But in other case, you have a problem regarding the vessel wall. In other case, you have a problem regarding the vasomotility. So I think we are just in the starting of understanding what to do with microvascular disease. So we need to characterize the mechanism underlying the dysfunction, and then try to look for drugs specifically designed for that kind of dysfunction. But again, I've already discussed this point. If you have an abnormal CFR and a borderline FFR, probably you are underestimating the stenosis. So especially in some setting, for example, in case of acute coronary syndrome. So you have if you test a non-culprit vessel during also some days after an ICS, and you have a borderline FFR value with abnormal CFR, you are probably underestimating the stenosis. So you should try to vasodilate more the microcirculation. So probably increasing the dose of adenosine or testing the resistance in order to understand if there is not complete response to the vasodilators. So this will be, of course, a new area of research and a new area of pharmacological drug development. Regarding the normal flow, I don't want to have a final position, because again, there is a discrepancy between these two interpretations, and I think the only way to overcome this problem is to design a randomized study.
Okay, thank you. We're almost at time, but there's just one more question. When you have these discordances, is there any role of non-hyperemic ratios? So let's say you're working in a cath lab, you get a discordance, you don't have coroventis or something to be able to do microcirculation. Would there be any benefit of using a sort of RFR, IFR, PDPA, or that's it? You have to make a clinical decision then.
So non-hyperemic indexes may be useful in this case, because of course they better correlate with flow. So especially in some situations where the microcirculation may be dysfunctional, you have a better correlation. So this has been also published in some studies. For example, there was a sub-study of the flare, the fine flare, and the sweetheart studies regarding IFR and FFR. And in the subgroup of patients with acute coronary syndrome, deferring the treatment of a lesion based on IFR was safer than deferring the treatment of a lesion with FFR, just because there is a better correlation of flow. So you are able to treat more accurate way the stenosis. So this is a good point. This is a very good point. So in the cath lab, if you don't have the possibility to assess the resistance, the microcirculation, you can use non-hyperemic indexes, because they better correlate with flow, and so give you a more conservative value.
Okay, thank you. So if we don't have any other questions, it seems, then we're just at time. So just leaves me to say, Graziella, again, as we've heard from Professor Nicoli, this was a really challenging study and a paper, so really well done. You presented it very nicely, so congratulations. Professor Nicoli, thank you for joining us again. We really appreciate your insights. I think the one thing I learned is that this paper probably raises more questions, and maybe we all need, this is all young interventional fellows connected, we really need like a deep dive into physiology. So maybe this is something we can all think about, how to arrange a session just to understand physiology better together. So thank you, everybody. Have a nice weekend and see you next week.